Good morning, everyone. It's a pleasure to be back here at CSTE, and I thank CSTE for inviting me, and especially for Megan for inviting me to speak. Megan and I worked together a dozen years ago, and that's why she knows how to pronounce my last name, I think. I normally talk about prescription drug overdoses, but I thought I'd take this opportunity to broaden that and talk to you about other problems that I think result from healthcare in this country. I know many of you work in infectious diseases and chronic diseases, and I thought that this might resonate with you, even though you don't work in injury or substance abuse. This is a slide that I think was frequently seen in debates and discussions about the Affordable Care Act and healthcare in the United States. It shows life expectancy per person on the y-axis, and healthcare spending per capita on the x-axis. And the USA is off on the far right. We spend 3 times as much on per person in adjusted dollars for purchasing power than the average of this group. This is the group of the Organization for Economic and Community Development. It includes developed countries like Portugal and Norway, middle-income countries such as Chile and Mexico. Our life expectancy is about the same in 2011 as people in Chile. We are 4 years ahead of Mexico. We are lower than a lot of developed countries. The U.S. soccer coach for the World Cup team believes that we should lose in soccer to countries like Portugal and Germany, but I don't think anybody thinks we should be losing in terms of life expectancy. So this is the broad context that I'm talking about. Perhaps the extra money we spend per person in the United States actually doesn't benefit us, and it may actually be have unrecognized harms associated with the intensity of healthcare, at least for some members of our population. How are we spending more money than other countries? Some specific examples. The treatments are in the first column. Our rank among those countries shown in the scatter plot is over to the right. MRI exams were second. CT exams were third. Tonsillectomy were first. Coronary bypass, knee replacements, cesarean sections. 1 in 3 live births now is delivered by cesarean section in the United States. The ideal is something like 10 or 15 per 100 according to the WHO. So my thesis, just to give you a preview, is that too much health care for some parts of the population. We pay costs in terms of negative health effects. We get fewer benefits than we realize. And I'm going to try to demonstrate that through the topic of pharmaceuticals now, a subject that I know better than others' topics. This is spending on drugs in the United States. We are about 5% of the world's population, and we spend about 34% of total global spending on medications. This is the total prescription rate in the United States. This is data from a commercial provider called IMS. The y-axis is prescriptions per person. This is just the spread of 6 years from 2007 through 2012. But we went up from 13.1 to 13.5 prescriptions per person during that span. Back in the previous decade, it was about 12. Before that, it was 11. There's been a steady increase in the number of prescriptions per person in this country. And the pattern's a little different. I'll show you by gender here. The bars represent different time periods, 1988, 1999, 2002, 2007 to 2010. Men are on the left, women on the right. In this period of about 20 years, the percent of the population using 3 or more prescription drugs in the past month has about doubled for both men and women. That's 3 or more in the past 30 days. And interestingly, the rates are and have been higher for women in terms of use of prescription drugs. About now, we have about 1 in 4 women who use 3 or more prescription drugs every month. These percents, by the way, are age-adjusted. Looking at it another way by race, ethnicity, same data source, same time periods. The prescription consumption is now, in the last time period especially, 2007 and 2010, higher in whites. African Americans are second, and Hispanics have the lowest rate of use of 3 prescriptions in the past month. The percents are age adjusted as well. So my point here really is that it's non-Hispanic whites who are the heaviest consumers rather than minority groups of prescription drugs now. A little background or definitions on prescription drugs. I was trying to draw a pill here. It came out looking like a bedpan. But adverse drug events are anything harmful that happens when a drug is taken. We're talking about pharmaceuticals here. And that can be whether the drug is taken as directed or taken for misuse and abuse. It can include drug overdoses, as well as infections from administration of drugs. Adverse drug reactions, sometimes called adverse drug effects, are a subset of the events, and these result when the drug is being taken as directed. So things like drug allergies or allergic reactions to taking a drug would be included in the adverse drug reactions. Just the adverse reactions are associated with there are about 2 million of them a year in the United States, according to some studies. And previous studies one study suggests there are 100,000 deaths a year in the United States from adverse drug reactions. That's been questioned since then. So the number is probably at least 10,000 and less than 100,000. But it's surprising numbers of people who die from this, and it's not reflected in mortality data. It's not a leading cause of death, but there are thousands of deaths related to the use of drugs, even taken as directed. Okay, so I'm going to move now to some, from the national perspective to on all drugs, to start to talk a bit about 4 specific examples of different types of drugs associated with drug events and drug reactions. I'll talk about antibiotics, spinal steroid injections, Fenphen, and opioid analgesics. Antibiotics. I'm sure you've heard many talks at CSTE on this topic. A recent CDC vital signs just this year talked about different kinds of adverse events can result from antibiotics. Clostridium difficile infections affect 250,000 people per year among hospitalized patients. There is a growing problem with antibiotic resistance and other adverse events. As I mentioned, allergic reactions. And antibiotics are among the most frequent causes of adverse drug events among U.S. hospitalized patients. I don't have too much more to say on this, but I thought I would include the results of this old study from 1994. It's kind of relates to the life expectancy curve in a way. As you move up on median household income, and this is in Atlanta in 1994, people have greater access to health care. And what this study showed was that the percent of penicillin-resistant isolates for strep pneumoniae increased with income in Atlanta then. So the infections were more common at the people at the lowest income levels, but this effect of drug resistance to penicillin was significantly greater as you moved into higher income individuals in this study. And in general, as I move through these examples, I'll try to say something about whether we're getting what we're paying for, or the effects. The topic of unnecessary antibiotics is also frequently raised at conferences such as this one. 30% of antibiotics received by hospitalized adult patients outside of critical care were deemed unnecessary in one study. Among outpatient visits for acute respiratory infection in one state, 68% resulted in an antibiotic prescription. But of those, 80% were deemed unnecessary according to CDC guidelines. So we have heavy use of certain classes of drugs with adverse events associated with them, and perhaps less benefit or less need than people appreciate. Another topic that I'm sure was discussed here at CSTE, spinal steroid injection and the consequences of it. Fungal infections associated with contaminated methylprednisolone were subject of a number of investigations in the last couple of years. One of the epicenters was right here in Tennessee. There were 61 deaths and 749 cases spread over 20 different states. Most of the patients were women, 59%. The median age was 64. Most injections were epidural, and most were for low back pain. There were a number of New England Journal of Medicine articles related to that outbreak. What I didn't see in them is how the pattern of cases, the people who were being affected, was related to the pharmacoepidemiology of who gets steroid injections in the United States. There is this study of people in Medicare with back pain from over a decade ago, and it looked at geographic variation. And they looked at epidural steroid injections, or ESI, and they found that the use of this modality was not really associated with the prevalence of back pain in different parts of the country. So it seems to be a matter of preferences locally and other factors that affect use. The rates varied eightfold from one state to another. The range among patients with back pain, 4% received an injection in Alabama, 0.5% in Hawaii. In general, the highest rates of use of this type of drug was in the South. If you look at smaller areas, as typically you get wider variation. If you look at health referral regions, the range is even wider, from 17% in Palm Springs, 17%, whereas 1% of Medicare patients in the Bronx, New York City, had received such an injection. And what I also didn't see in the New England Journal of Medicine articles was any discussion about the effectiveness of these kind of injections. There have been actually, just in the last couple of years, a couple of reviews. There was a Cochrane review of injection therapy for subacute and chronic low back pain, and remember, most of these cases were being treated for low back pain. They concluded there was insufficient evidence to support use of injection therapy. And another review and meta-analysis in the management of sciatica, lower back pain radiates down your leg, said that injections only offer short-term relief of leg pain and disability for patients with sciatica. So some of the people who wound up with infections and got injections may have gotten no benefit from that medication. And the use of that medication and geographic variability and resulting in high rates in some communities may have been an important risk factor for the occurrence of those cases. Changing topics. Obesity, for the people in chronic disease in the room. This is another fairly old story, but I call it the binge and purge of Fenphen. And it has to do with a class of diet drugs called Fenphen. This happened in the 1990s. But the antecedents to it was an emphasis on obesity, which became greater around the 80s, late 1980s. The Surgeon General's report on nutrition and health said that over 30 million Americans were overweight, and they recommended treating obesity like any other disease. In 1993, a well-known paper from CDC authors, McGinnis and Faggy, tried to establish the actual causes of death. So they identified not heart disease and cancer, but risk factors like smoking, lack of exercise, and so on. And they concluded that some 300,000 deaths a year in the US were due to a poor diet and activity patterns related to obesity then. So we were seeing this as a disease, and we began to treat it as a disease. And there were many pharmaceutical companies and researchers at the time trying to find effective drugs to treat the chronic disease of obesity. In 1992, a clinical trial was published by Weintraub. 121 patients, mostly women. He gave them a combination of fenfluramine, which is a drug that works on serotonin metabolism, and phentermine, which is amphetamine. And many people have taken speed or various kinds of stimulants to lose weight, but the results weren't all that good, and people had real side effects from the drug. Fenfluramine was kind of sedating. People were kind of loggy when they took it. So Weintraub's idea was to combine the two drugs in this trial, and the package became called Fenphen. In 1996, Wyeth put out a new proprietary product, brand name, dexfenfluramine, which was just the dextroisomer of an older drug. The older drug, fenfluramine, was coming off patent, so they came up with an isomer of the same drug and were able to get approval for it. It was the first diet drug that FDA had approved for over 23 years. They approved it only for moderately to severely obese people for long-term maintenance. And it was the first drug that got labeled for use for long-term use. So what happened? There was really a frenzy of Fenphen sales. The trial had advertised a 30-pound weight loss. The doctors prescribed the drug Redux combined with amphetamine. 3 weeks after Redux was approved, doctors were writing about 85,000 prescriptions per week for the combination. It really wasn't an approved combination, but the study had shown the effectiveness, so it was being prescribed that way. And in actuality, we had pill mills. Like we have now for opioid pain relievers, there were pill mills in Florida and California where you could practically drive through and get prescriptions for Fenphen. And eventually up to 5 million Americans took fenfluramine or Redux. And after a while, people began to look at the effects. This is a cover from Time magazine from September of 1996. This was such a popular topic that Time put it on the cover. Redux really seems to work, but is it too good to be true? And I think they're prescient in that headline. It was just November of 1997 when DHHS came out with recommendations on Fenphen. What had been found was that use of the drug in some people who had only used it for a few weeks, but mostly in people who used it for several months, the drug was associated with cardiac valvulopathy, vegetations growing on your heart valves, and it was associated with primary pulmonary hypertension, which has a very high case fatality rate. And these were public health recommendations put out in MMWR. And as it turned out, the millions of people had taken it, tens of thousands of cases. The actual studies that the manufacturer had done and submitted for the approval of Redux showed that the intervention group lost 5% of its body weight. It wasn't really 30 pounds. 5% is just 6 pounds. The placebo group lost 2%. So the difference of 3% was what was the result of use of the drug. After people stopped taking the drug, they regained the weight. And as it turned out, after it was marketed, the drug was used by many people who were not moderately or severely obese. They were taken by people to look better during the summer on the beach, to lose a few pounds for a wedding, and a number of deaths actually resulted from use of the drug, particularly from the pulmonary hypertension. 1 out of 3 people with a valvulopathy needed valve replacements. And now, fourth example, circling around to my favorite topic of, again, of opioid analgesics. We've had a problem, of course, in this country with increasing overdose deaths that you've heard about. 12 straight years now of increasing deaths. But really the problem began a long time ago, 25 years ago now, when pain specialists began to change their mind about use of opioids for chronic pain. This 1986 paper was put out by two preeminent pain specialists in New York City, Russ Portnoy and Kathleen Foley. And they had studied 38 cases and had prescribed to these folks opioid analgesics for non-malignant pain. It had been accepted, of course, that people with terminal cancer should get opioid analgesics, people with acute pain, opioid analgesics, post-operatively, yes, short term. The big issue here was use for chronic pain, and that's where this issue started. So the authors were cautious in the way they put it. They knew they were only studying 38 cases with very severe pain. They said that the present survey is suggestive evidence that opioid medication can be safely and effectively prescribed to selected patients with relatively little risk of producing the maladaptive behaviors which define opioid abuse. Given the paucity of data, and they only have 38 cases, this course must be pursued cautiously. Well, there was this study and one other study, basically, that were the starting point, really, of a long, steady increase in the early 1990s of use of opioid analgesics, which resulted in increases in misuse and abuse of the drugs and fatal overdoses. This was, I'll show you a couple of ads here. You know, this is for, basically, this is a drug, Vicodin. This ad was from the 1990s, and it announces freedom from pain. The drug is hydrocodone, which has been around for decades, but there's a new enthusiasm for the use of it. It promises almost miraculous results. You can turn from the Incredible Hulk into an upstanding, healthy person in a very short period of time. And they advertise it as the drug that's the most potent analgesic that you can phone in. This is an ad in medical journals to physicians encouraging them to use this drug, which is a drug that you actually could phone in prescriptions on refills over the telephone. And then a new drug came on the scene which facilitated the problem. And it really was one of several drugs, but this is Oxycontin. This is a 1997 ad. It came on the market late in 1996. And the man who looks like he's cut off from real life there says, "I want to focus on my life, not my pain." And it's for pain lasting several days, weeks, months, or more. So the idea was that they're marketing to people with chronic pain, musculoskeletal problems, back pain, arthritis, even headaches, diseases that we don't have a cure for. We just kind of treat, and you may be on the medication for the rest of your life, and I think that was the idea here. Oxycontin sales, it's a form of oxycodone, went through the roof. There were less than 1 million in 1996. By 2002, there were some 7 million prescriptions. Interestingly, 2002 was the first year when we started hearing reports, and they came from state health departments. Case Anford in North Carolina was one of the first people to raise this issue. The medical examiner in Maine also reported cases. It was West Virginia had a problem. They started calling it hillbilly heroin, and the impression was that this was limited initially to certain parts of the country. Well, the OxyContin problem really did have some geographic concentrations, but opioid analgesics in general were widespread in their use across the United States. This is more recent data on sales from 1999 through 2011. Sales are shown in yellow, and these are kilograms per 10,000 people, data from the DEA. The white line in the middle are rates of opioid analgesic overdose deaths. I said 12 successive years of increases, and this is where that comes from. The data now from 2011 is just out. I know it's 2014, but the data from 2011 is just out, showing another increase in 2011. And the blue line is treatment admissions, a rate, data from Substance Abuse Administration, showing really an acceleration of people going into treatment where the primary drug of abuse was prescription opioid analgesics. So the problem has come a long way since that original paper in 1986 through Oxycontin in the 1990s. We've continued to see these increases. And this gives you a longer time trend. I guess it helps to put it in context. These are death rates broken down by race and ethnicity. This goes from 1979 through 2011, vital statistics data. Up through 1999, I'm only showing the white and black rates. Basically, white and black overdose rates in the early 1980s were very similar. There were lots of problems with cocaine, crack cocaine in late 80s, early 90s. Black rates rose somewhat above white rates during that period of time. By the late 1990s, however, the rates were starting to come back together. In 1999, blacks, non-Hispanic whites, and Hispanic whites, shown in the white squares here at the bottom line, all had fairly similar rates. But we can separate the data by ethnicity, and so I've split the white line into non-Hispanic going up and Hispanics below that. And what you can see is that this problem of drug overdose, which is being driven by the opioid analgesic overdoses, has really been affecting the non-Hispanic white population. And remember, the non-Hispanic whites are consuming the most prescription drugs in general in the United States. The Hispanics, African Americans, have been affected to some extent. Their trends are still going up. But really, this is a more of a rural than urban problem in some ways, focused on low-income, non-Hispanic whites in many states. Well, this wasn't the title of the slide. This was a slide that has about 6 different headlines from different papers on them. And the only one that seems to should be showing up is this one. Basically, the titles were from eminent researchers in the field of pain medicine, saying that they are losing their faith in opioid analgesics. These papers, if you could see them, they were from 2010 to 2012. So just in the last few years, there's been a sort of a paradigm shift, or the consensus is breaking up about use of opioids for chronic pain. And many healthcare providers are thinking twice about this and reducing their use. Oh, sorry. They're all here. Let me just bring them up. That's what you get when you borrow somebody else's slide. So just to reiterate, they talk about time to change prescribing practices, facing up to the prescription opioid crisis, reconsidering a flood of opioids, a rising tide of deaths. And lastly, JAMA had an article talking about how patient satisfaction is probably associated with greater use of prescription drugs, but also with adverse or unintended consequences. And then just to conclude this topic on the issue of effectiveness or impact, are these drugs needed? Do they work? Are we getting the bang for the buck? Unfortunately, the conclusion of the most recent literature is that there's a lot of holes in the initial story proposed by Portnoy and Foley that they were effective. The Women's Health Initiative study, looking at women 50 to 79 with chronic pain, followed them for 3 years, and they found that baseline opioid analgesic use for their pain was associated with no improvement in pain long-term and worsened physical functioning. They got no better in their ability to carry on activity of daily living, to care for their families, to go to work. Another study looked at chronic opioids for osteoarthritis, a common use, and said that the benefits are small and they are outweighed by large increases in the risk of adverse events. And finally, a recent review by Noble said that the data on long-term safety and efficacy of opioid are limited. So what people are saying now is that it doesn't really work and the juice is not worth the squeeze. So to try to pull together all these different threads, there are some common themes across examples that I've shown. Increasing use of drugs in general in the United States, especially for treating chronic conditions, back pain and obesity. Drugs are being marketed for what is being called public health problems, ironically. I mean, the obesity issue was a public health problem, an epidemic of obesity, which sort of laid the groundwork for increased use of drugs to try to address that problem. Pain, Institute of Medicine had recent reports saying that 116 million Americans live with chronic pain and calling it a public health problem. The problem is that the drugs that are used to address these problems are tested for much shorter periods of time and on atypical populations compared to how they are used in practice. They're not really being used for selected patients, as Portnoy and Foley suggested. We've stumbled because we didn't really realize the limitations of effectiveness and the risk. They also aren't being used for patients with severe conditions. The milder disease is oftentimes the majority of the patients. And across many of these categories, white women are in the highest risk group. Fenphen, opioid analgesics. Women are prescribed many more opioid analgesics than men in the United States, as well as many more stimulants in middle age. And it is, there are real strong racial and gender differences in the outcomes related to the patterns of use. So adverse events from healthcare are significant public health problems, and I tried to talk about pharmaceuticals in this context. Are the benefits in excess of the risk? Not always. We have to look very careful at the question. We have really a limited appreciation of the possible consequences of new medical technology, whether it's surgery or drugs. And there certainly are populations who need more painkillers, who need more drugs, who need more surgeries. The problem is that we have other parts of our population who need less than they are receiving. And we need to reapportion care in our communities so that more of it goes to the people who really would benefit from it. Thank you for your attention. Question. How much time have we got? 5 minutes?
Yeah, we've got several minutes for questions. If people will come to the microphone to ask their questions, that would be helpful.
Over here. Hi, Len. Thank you for your talk and broadening your scope besides opioids, because we've heard a lot of that here in the injury sections this week. I just had a question and wondered about changing provider prescribing practices. In Washington State, we've been working on that for quite some time, and given all of the research that shows opioids are not so effective for chronic pain, the prescribing is coming down very slowly, but not as steep as you might expect. So any comments on that?
Yeah, that's a good question, Jennifer. You know, I think that the most common approach has been clinical guidelines, and a lot of them come from medical societies and a number of states. Washington was perhaps the first, Utah. I think we now have 8 or 9 states that have statewide clinical guidelines on the use of opioids for chronic pain. But as in any kind of guidelines for its use of antibiotics or anything else, it has to be put together with some sort of accountability, if you will, or some sort of measures to to see whether they're really being adopted. So Washington State has succeeded in bending the curve to some extent in its opioid analgesic use. And yes, there's some indications that nationwide the rates are topping off in 2012 for opioids. But it's a small change, so we would hate to plateau at this point and still have 17,000 opioid overdose deaths a year going forward. Perhaps other strategies that states have adopted, that states who have serious problems with this issue, such as Tennessee, as a matter of fact, is regulation. And New York and Tennessee, Kentucky now have regulated prescribing such that prescribers have got to go check the patient's history in the state prescription drug monitoring program to see what their patterns of previous use have been. PDMPs, prescription monitoring programs, are based on all the prescriptions submitted by all the pharmacies in your state. They go to somewhere in the state capital, typically. Every state but Missouri has one. And in the vast majority of states, providers can now get pretty quick access to that data. The idea is to see whether your patient is using drugs provided by other doctors, has been using drugs, how long they've been using them, what the dosages have been. It may be reassuring in some cases to know that the patient has been using them appropriately. And in other cases, doctors identify patients who are seeing 5, 6, 7, 8, 10 physicians for the same kind of drug. In those states, New York and Tennessee, they've seen substantial declines in the use of multiple providers by doctors, and some substantial declines actually in the use of certain classes of drugs. So there is really a sort of a change going on as some of the early measures that are primarily educational are shifting towards things with more teeth in them. Washington now has a regulation itself in terms of prescribing. And there may be other regulations going forward regulating pain clinics, which are called pill mills in some states. And that may also be a promising strategy for reducing the most problematic of prescribing, and substantial reductions in overdose deaths might result.
Bryant Karras, Washington State Department of Health. Wonderful presentation, and you anticipated my comment. Thank you. Okay. The question I have on top of that point about prescription drug monitoring programs or controlled substance registries, is there good evidence that these are going to make a difference, or are we in fact going to be driving these patients, because it will reduce the use of these medications, but will it drive our patients to illicit drug use? They take them from the hillbilly heroin to actual heroin. Yeah. And can you comment on that? And what do we need to do to treat upstream the original cause or anticipate this unintended effect of our intervention?
Another good set of questions, Brian. Early studies, some of which we did, showed PMPs in the early part of the last decade didn't seem to have much of an impact on overdose rates or prescribing. They shifted people to Schedule III drugs, which are less regulated than Schedule II. But that was about the extent of it. More recently, however, doctors are actually starting to use prescription drug monitoring programs, and they didn't work too well when the data was being collected and it wasn't getting out. It's starting to get out now, so there may be more promising results from that. And associated with requirements for use, it might actually affect things. The shift issue, many of you, perhaps most of you, have problems with increasing rates of use of heroin. Heroin overdose deaths have been increasing across the country, probably more in the eastern part of the United States. What's found from survey data from SAMHSA, again, is that 3/4 of those folks started on prescription opioid analgesics, and that they have shifted either because they lost their insurance and they're no longer paying a copay for Oxycontin, but were paying street prices, and heroin was cheaper on the street, or Some people have reported in qualitative studies that the new form of Oxycontin, they can't crush it anymore and it can't inject it. So for the IV drug users, the long-acting drugs like Oxycontin and Opana, which is oxymorphone, were popular. They're both abuse-resistant now. Some of those folks may be shifting over. What we're seeing, though, is that there's no close connection between changes in prescription opioid rates and changes in heroin rates. Places like Florida that have seen dramatic declines in opioids have not seen compensatory increases in heroin that make up for the difference. The answer is to get ahead of it, to reduce the prescribing so we don't keep increasing the population of people who are dependent on some kind of opioid. Most people start with a prescription for themselves, and we have to damp that down and make sure it's used really when it's appropriate and effective and after other things have been tried. Okay. Thank you.